Welcome back, everyone. And for those of you just joining us, welcome to Measuring Development 2021, Emerging Data and Methods in Global Health Research. I'll be chairing our second research panel of the day, which will focus on novel data and methods for disease tracking and response. This is our longest panel as well. We have 6 speakers. There is so much exciting work going on in this space that we didn't want to limit. So we will actually be breaking halfway through this panel for a first set of Q&A. And then at the end of the panel, we'll have another Q&A. So let me start by introducing all of the exciting speakers that we do have in this session. First, we'll have Awaz Akhtar, who's a development practitioner with interests in public health, education, and using large-scale analytics for improving service delivery in resource-constrained contexts. He holds a graduate degree in economics from Georgetown University and is affiliated with Indus Health Network and Center for Economic Research in Pakistan. Second, we'll hear from Sveta Milusheva, who's an economist in DIME at the World Bank. She coordinates the iConnect program of impact evaluations focused on transport investments, and within this program leads the work on urban mobility. Her research interests include infrastructure and information and communication technologies, population mobility, health, and gender. In particular, her work focuses on the application of new big data sources, such as mobile phone data and crowdsourced data, to study questions in development and evaluate the impact of development interventions. She received her PhD and MA in economics from Brown University and her BA in economics and international studies from Emory University. Third, we'll hear from Ifeoma Ozedugo, who is a postdoctoral fellow with Dr. Jaylene Gerardin's lab in the Department of Preventive Medicine. She received her Doctor of Public Health in Epidemiology from East Tennessee University in May 2019, where she was a Rotary International Global Grant recipient. At the Dr. Gerardin Lab, she leads dynamical modeling for understanding the impact of malaria intervention mixes in Nigeria and supports analytical projects that evaluate spatial variation in malaria transmission within endemic countries. After those 3 speakers, as I said, we'll have a short break for Q&A, and then we'll hear from 3 more. Guadalupe Bedoya, who's a senior economist in DIME at the World Bank. Her research focuses on the role of accountability mechanisms to reduce market failures, particularly in safety markets, such as patient safety, road safety, and building safety, and multifaceted interventions to reduce poverty in fragile contexts. She received a master's degree in economics and public policy from Princeton University and a PhD in public policy from the University of Chicago. Before joining the World Bank, Lupe worked at the Inter-American Development Bank and the Ministry of Finance and the Ministry of Economic Planning in Colombia. Next, Dr. Laura Balzer, who's an assistant professor of biostatistics at UMass Amherst, where she directs the UMass Causality Lab. For the past 10 years, Dr. Balzer has been working to prevent HIV and improve community health in rural Kenya and Uganda. And finally, we'll hear from Jonathan Kolstad, who's an associate professor at the Haas School of Business, where he holds the Henry J. Kaiser Chair and in the economics department at UC Berkeley. He's also a research associate at the National Bureau of Economic Research. His research interests lie at the intersection of health economics, industrial organization, and public economics. Kolstad was awarded the Ashcon Medal in 2018, given biennially to the economist age 40 or under who has made the most significant contributions to the field of health economics, the Arrow Award for the best paper in health economics in 2014, and the NIHCM Foundation Research Award in 2016 and 2018. Professor Kolstad is also a co-founder and was chief data scientist at Pickwell. Professor Kolstad received his PhD from Harvard University and BA from Stanford University. So without further ado, let me hand it over to Awaz Akhtar to get us started off.
Hi, everyone. I hope everyone is doing great. I'm just going to share my screen. Be ready to go. Okay, hi everyone. Welcome. Pretty excited to be presenting the work I did over the past 1 year with Indus Hospital and Health and Network, and I hope we have some really good things to take away from this presentation. So a bit of a background of Indus Hospital and Health and Network. It is a Pakistan-wide a network of primary care facilities and first and tertiary level hospitals. one distinguishing feature is that at all the facilities, treatment is provided free of charge, and with partners, and it works with a range of private sector and government partners to advance the cause of health equity. Um, in terms of setting, I'm going to present more about Karachi, the city. It's a densely populated city of more than 16 million, and with an annual tuberculosis incidence of 265 for 100,000 people. And I mention this fact specifically because many of the risk factors for the spread of tuberculosis have a large deal of overlap with that of COVID as well. Also, in terms of Indus Hospital and Health Network in particular, it has a fleet of mobile van-based mobile vans that provide services for TB detection, and it's important because it will provide us a bit of an infrastructure to work with when COVID actually hits and lockdowns begin in March 2020. So this is a Karachi city pretty well spread out, and we have our vans which are in a place which are either serving communities in fixed areas as shown in green, or in red where they are free to move throughout the city. And as we all know, the challenges were plenty, a lot of unknowns, uncertain policy environment. There was apprehension among not only health workers but in the community as well, and the capacity for contact tracing and coordination with local authorities had to be built from the ground up. So we started thinking about what we could do in order to just make the situation better overall. And our diagnosis of the problem was that of an information vacuum, and we just wanted to do everything on our end to ameliorate that. And we all know in a pandemic, a location of cases matters more than everything else. So this is an activity that we had been doing earlier on a smaller scale of geocoding, where the patients were coming from, but we amped it up in multiples to the entire testing exercise that was being carried out. And it took as input information from all possible sources, such as labs, TB vans, and also community contact tracing. And it had outputs tailored to public health organizations, the government, and community-based actors as well. So in this slide, what you see on the right side is information that is probably relevant for a government official to see, what is the extent of testing that's taking place across certain districts of the city, and where are emergent COVID hotspots. So I'll just go into a bit more detail on what the outputs look like to the teams that were actually implementing. So in front of you, you can see that the smallest geographic area that you can see is the Union Council, and what our geocoding of all available testing information enabled was for people implementing on the ground to exactly identify where to target their contact tracing and their other testing resources as well. I'll speak a bit about how it worked in practice. So this graphic, I hope it helps in that regard. I mean, there were field teams and vans and also labs as well, which were conducting COVID testing. All of that information was being fed into the centralized health MIS. And from that, we had to be cognizant of maintaining privacy of patients. Only the address was extracted, and we used the Google Maps geocoder API at scale, and what we did was that we connected it to a web app, which would automatically start geocoding at every instance when data was pushed out. We use open source solutions as much as possible, such as QGIS for the eventual mapping. And we completed the feedback loop in the system as well to ensure that, for example, the activities that the field teams were conducting on the ground were also going back into the health MIS system. So, for example, mental health counseling for COVID positive, it was being captured in some way, and the feedback loop was basically being completed. So a bit about the data. I'll focus on the first few months of the pandemic, and from all the samples tested using our sort of enhanced information and targeting of resources, we got 22% of a positivity, and when we compare it to what was happening nationally, it was at the end of April it was 11%, and at the end of May the positivity rate at the end of May 2020 was 12%. So by concentrating our resources, we were doing significantly well in that regard. So let's say something about what worked well and what didn't. So we had an 87% hit rate for well-defined addresses, and what I mean by well-defined addresses was that it wasn't an ambiguous address and it wasn't missing any information, but I allow spellings in that. Overall, it was super quick to set up, and we had this system up and running within days, and both the field teams and the government partners it added a value to their operations, and using this workflow, we have managed to process about 500,000 tests so far. And this is an example of our team hard at work, performing testing in the community and, feeding information back to our centralized system. We also should say a bit about what did not work. We faced a problem with incorrectly entered addresses. It affected about 23% of all testing data, but the problem faced was much lesser in magnitude among positive cases. But more importantly, what we found in this entire episode was that although uh, the data capabilities of ours advanced, and we were able to say, okay, these are the areas where the testing resources should be focused. It wasn't always possible to do so because of capacity constraints within the health the system at large. And I think that was, I think, the limiting factor, rather than all these novel methods of tracking pandemics, etc., that we come up with. And this is just another example of the various models that were tried out using the infrastructure support that was provided by the TB van. So we had a walk-through, a drive-through, and then again work within the community as well. So we have I mean, we are very excited by the potential of this method, and I mean, this image would be very familiar in form to folks at SIGA, and the work that Josh Blumenstock has done with making a poverty map. That this is some work that we've just done very recently, and we just using the power of where of knowing where the patients are coming from, and what sort of general issues that they are faced with, to say something very some very powerful things about the areas that we serve. I would say that in the past 1 year or so, I have gotten to know my city much better than I had known it earlier by using these methods, and the big idea that I'm sort of more working towards is sort of pinning down the geography of the health, because from surveys such as DHS, the surveys our understanding of health patterns or disease patterns tends to be more at the macro level, and if we are going to advance the cause of health equity, our understanding needs to be as localized as possible, and we're trying to pin down and work through methods that do that. So in conclusion, I mean, privacy preserving methods are a very powerful way of studying localized, I should have added here, disease and health trends. And but in contexts such as ours, they work best when they are paired with robust community outreach mechanisms, and it's much easier to scale methods rather than scaling things like community responses, which obviously flags the need for more investment in health systems.
Sorry to interrupt, but just to encourage you. Oh, perfect. You're wrapping up. To encourage you, the time is up.
Yes. So yes, I've so that's the end of my presentation. I mean, I'm happy to provide more information and discuss more ideas with everyone out here. Thank you so much for your time.
And thank you so much for the really interesting presentation. I'll hand it over now to Sveta.
Hi,
Sveta,
everyone.
you're
Yep. Still forgetting to unmute. Okay, let me just share my screen so you can see my presentation. Um, all right.
Great, we see your screen.
And is it now in full mode?
Yes, it is. Thanks.
Perfect. All right, great. Thanks so much, everyone, for joining. I'm really excited to have the opportunity to present today some new work on modeling disease spread using agent-based modeling and cell phone data. This is joint work with Sophie Eiling and Sarah Wise at UCL. And there have also been many others that have contributed to this work over the last year. So the research question that we aim to answer is, what is the relative spatial risk of disease transmission and risk of severe disease in different parts of a country? We've been focusing on the current COVID-19 pandemic, but the goal is to actually think about how this type of work could actually be applied to other diseases in the future as well. And the goal has been to develop tools that can be useful for governments and planning, and to be able to think about, for example, resource allocation, like where vaccines should be distributed. So the methodology kind of has three parts that all build on each other. The first is modeling static risk using data such as demographic health surveys to look at variables that we know are correlated with severe COVID risk. We then integrate mobility data, which comes from mobile phone records. And this allows us to understand how mobility is related to spread of COVID. And again, thinking more broadly about other diseases as well, mobility is oftentimes quite critical in terms of a disease spreading to new areas. And finally, we bring these different data sources together to build a model of transmission risk. And we develop an agent-based model that allows to combine the data from population characteristics, disease risk factors, and mobility. And this allows us to model the spread of the disease, as well as to model different scenarios that allow us to look at things like vaccine distribution and what the relative impacts may be on reducing cases and deaths. So first, jumping into modeling risk factors, and I should say all this work is actually still ongoing, so I won't be showing any findings or any kind of final results, but we'll walk you through the process in the different pieces that we've been working on to give you a sense of how these data can be used. So first, with modeling the spatial risk within countries, we work with demographic health survey data. DHS data is collected across many countries in the world, and it provides information on the GPS location of the clusters where the data is collected. And so that's what you can see in the map on the left, and where we look at a number of different variables that are potentially linked to COVID and severe COVID. And in this case, we're looking at hand washing risk, which is defined as risk of not having the resources needed for proper hand washing. And so we start with the GPS location of clusters that represent a number of households that have been interviewed. We then use spatial interpolation to create a raster file like the one shown in the middle. And that allows us to have risk for the whole country. And then we aggregate it using population weights in order to get values at the district level. And that's the map on the right. And so using this method, we can develop risk factors at a fine spatial level for different factors that we know are related with COVID. Additional factors we look at, for example, are anemia on the left here and also smoking on the right, both of which have been shown to be highly correlated with severe COVID risk. In addition, as I mentioned, we then bring in data on mobility. As I mentioned, for mobility data, we use mobile phone records. Now, what do we mean by mobile phone data and records? These are call detail records that are collected for billing purposes by mobile phone operators. These consist of data points whenever someone has a call, a text message, or uses data on their phone. And we have an observation with a user ID, timestamp, and the tower that is linked to that observation. And so you can, in theory, trace individuals over time based on the user ID and the timestamp, and then know if they're changing location based on differences in the tower. This data can be anonymized, but it's still quite sensitive. Because of this sensitivity, one of the first things we do is to create systematic indicators. So we work with the mobile phone operators to aggregate their data into indicators that can be used for modeling disease and for the models I'll show later. And so in this way, we're able to still have very useful data while preserving privacy of individual users. And some examples of the types of indicators are shown on the right. So we can have, for example, count of unique subscribers that gives us a sense of the density of the population in different areas, origin destination matrices between different areas. So we can see how two regions, for example, are connected with people traveling between them. And we usually do this on a, calculate these on a daily basis. So it's, again, very high frequency, both spatially and temporally. And in doing this process, all of the code that we developed is open source and available online. So others can also produce these types of indicators in partnership with MNOs. And this is just an example to see what this type of data looks like. So here we create a dashboard with this type of data for one of the countries where we work. So this is for Mozambique. And you can see how the data, again, is at a very fine spatial level. So you can see kind of all across the country differences, both in the number of subscribers as well as the change in number of subscribers in an area. And we can see that on a daily level. So it's quite detailed information that is very useful when thinking about spread of disease, especially when we start to look at mobility. So for example, we can see where people are traveling, all the different districts where people travel to from a specific area. And so then we can understand if there's an outbreak of a disease in one area, what are the areas that may be at highest risk where the disease might spread. Additionally, we can run regression analysis to see what is the relationship and to quantify the relationship between COVID cases and mobility, whereby we combine mobility with case numbers to be able to calculate not just how many people are traveling from location A to location B, but potentially how many infected people are traveling from location A to location B based on how many cases are in location A. So the likelihood that someone coming from a location is actually infected. And that's what we're calling here imported cases or expected imported cases. And so we can see the relationship between the lagged imported cases, so how many potentially infected people came into an area last week, and how many cases we see in the area this week. And we do see a positive and statistically significant relationship between mobility and spread of the disease. And this type of analysis, again, can be run for different countries and also for different diseases as well. Additionally, we can combine the mobility data with the risk data that I showed earlier in a pretty simple way. So we can look and see which are the regions where we see both high risk in terms of mobility as well as high risk in terms of risk factors that would increase the likelihood of having severe COVID-19. And so what we're showing here are each dot represents a different district, and I'm doing this for 2 different countries. And we can see which are the districts that have higher than the mean or higher than the median of both mobility, whereby here we're calculating mobility as the number of different regions from which people are coming, as well as those that have very high risk of severe COVID-19. So the first piece, the mobility, allows us to understand where the disease might spread or is more likely to spread. And then combining that with the risk factor, it tells us which areas where it spreads to may see more severe COVID because of specific characteristics of the population. And so they may also see higher levels of death rates. And so then what we would want is to use this to be able to understand where we should be targeting resources and what may be the areas at highest risk where we should be focusing attention especially. And then finally moving into the agent-based model, where we bring these different pieces together into a more epidemiological model. Agent-based modeling is a technique whereby we simulate individuals, which allows us to look at heterogeneity in how people interact and their characteristics. So in the visualization on the left here, each dot represents a person, and we can see how different people are linked together. And then we also can seed infections into that, which allows us to then do a lot of different scenarios in terms of what if we were to change things about this kind of current situation, or the situation as is, and what the impacts would be on spread of the disease. And we first started out working with an existing agent-based model called COVASIM that was developed by the Institute of Disease Modeling at the Gates Foundation. And we apply this to the Democratic Republic of Congo. We use a sample of the population scaled up. We have home, community, school, and work environments where we have individuals. And so we can simulate then how they interact in these different locations and how that affects the transmission levels. And so the first thing that comes out of this type of model is just the total case counts that we would expect. So how many infections each day, which is shown on the bottom right here. And then this can be compared with what we actually know is happening in terms of number of cases in a country, and then to use that to calibrate the parameters in the model to ensure that it's properly modeling the specific circumstances in a given country. Once the model is calibrated, then it's possible to look at different scenarios. For example, one of the important pieces right now to think about is vaccine distribution. We can consider, if we have a set number of vaccines coming into a country, what is the best way to distribute those? For example, what are the age groups that we may want to target those towards, or potentially occupations that we may want to target those towards, which then would allow us to see the highest decreases in deaths and in cases. And so again, this is all work in progress, but to kind of show you the type of modeling and outputs that we aim to produce. And while we've been working for now with the existing model, we're also building an agent-based model that's a little bit more complicated than the COVASIM one, in that we also want to incorporate the mobility data from the cell phones that is not currently included in the COVASIM model. And so we want to be able to also understand how travel between districts may affect spread of disease. And here I'm just showing another visualization on the right, where again, we can see a little bit closer the different individuals and also their occupation. So that's another piece that we're incorporating is also the occupations of different agents, so we can understand how that will actually impact spread of the disease and how these different linkages will affect the number of cases and the number of deaths. And then we hope to combine this also with the risk data from the DHS that I showed at the beginning that can better help us understand also the risk of severe disease and how that is impacted as well. So in summary, there's an incredible opportunity to leverage different types of data to study the spread of disease. We can bring together traditional data sources such as census data and DHS data and combine it with new data sources such as mobile phone records. And there's different levels of modeling that are possible, as I've demonstrated, starting from simpler spatial modeling, going all the way through regression modeling, and finally this much more complicated agent-based modeling. And all of these can provide policymakers with useful insights that can help to support more effective policies. And again, that can be applied not just in the current circumstances, but also thinking about future pandemics and even existing diseases that may be important to target. So I'll stop there and thank you very much. Looking forward to any questions.
Fantastic. Thank you, Sweta. Really, really interesting work. I hand it over now to Ifeoma.
I'll just go ahead and share my screen.
Please.
So
Great, we
I
see
think,
it.
okay. So the last presentation was really a good transition to my presentation, which is on how we worked with the Nigerian Malaria Elimination Program to identify the most appropriate interventions for each of Nigeria's 774 districts. We used an agent-based model as well, but also as part of my talk, I want to highlight how these interventions that we supported the Nigerian Malaria Elimination Program to select relate to global targets for reducing malaria morbidity and mortality. So to give you some context, Nigeria contributes 23% and 27% of all global malaria deaths and cases. So this makes Nigeria the greatest high burden malaria country in the world. The global malaria community envisions a world where malaria is eliminated, and they've set ambitious targets for reducing malaria morbidity and mortality. These targets, known as the Global Technical Strategy Targets, or GTS targets, is geared towards reducing malaria burden by 40% in 2020, which is represented by the yellow line you see, the yellow dot you see here. And there's also targets for 2025 and 2030, which is reductions by 75% and reductions by 90%. This plot you see here marked out in pink is malaria deaths in Nigeria over the last 10 years. And you see that Nigeria has made incredible progress, but this progress is slightly stagnating in the recent times. We see also the same picture for malaria incidents over the last 10 years, and the discrepancy between malaria incidents in 2019 and the GTS targets is quite high, meaning that Nigeria won't be able to accomplish any of these targets. In order for us to meet intervention targets, the High Burden to High Impact Initiative was launched in 2018 by the World Health Organization, as well as the Rollback Malaria Fund, to support high burden countries to identify how to use local data to inform intervention targeting. And in the case of Nigeria, what this implies is that Nigeria's individual 37 states, which typically in the past would have uniform malaria interventions, would now have much more tailored interventions. But how do you make the decision for what interventions would look like for each of the 37 states? The 37 states in Nigeria also contain districts, and the previous presenter had talked about the fact that we need to tailor interventions to districts. Nigeria's districts, however, are 774 districts within 37 states. And so this means that this is an extremely challenging decision to make, because you have to consider several factors, which includes malaria epidemiology and also the history of interventions. So what this calls for is, given that when you stratify interventions, because that is what the NMEP is currently doing, is that they stratify interventions based on recommendations from the WHO and considering epidemiology, entomology, health system related factors. But they come up with a variety of scenarios, and how can they select which scenario will be most appropriate when you have 7 potential intervention scenarios? And that's where we support the NMEP, is that we use quantitative tools to help them make that decision by predicting or using mathematical models to provide a framework for for modeling malaria and interventions. And so what that would look like is that we would take a very complex problem like malaria transmission, we would simplify it, abstract it into a mathematical model, and simulate, using our agent-based model, which is an individual level model as described previously. And then we would simulate malaria transmission, intervention dynamics, and then come to conclusions. So in essence, our goal was to simulate in the future or predict the impact of a set of intervention mixes that were provided by the NMEP on malaria morbidity and mortality for each of Nigeria's districts. And this was for the period of 2020 to 2030. We then aggregate these results to the state and national level for purposes of presentation. So our model was developed within eMod. eMod is an existing agent-based model developed by the Institute for Disease Modeling, and it is a model of vector population and vector life cycle that is coupled with a model of human disease and human immunity, as well as intervention effects. So there are 3 things that we want to capture within the eMod in order to describe or simulate malaria transmission. One of them is seasonality, the second one is transmission intensity, and the last one is intervention effects. We capture seasonality from routine data, which is data that arises from reporting health facilities in Nigeria. However, we're unable to use this data source to capture transmission intensity because, as many previous speakers have described, data from lower and middle income countries tend to have, and as well as data elsewhere anyway, tend to have lots of biases. And in this case, the bias is that the data only comes from reporting health facilities. And people that are familiar with Nigeria will know that most people seek care from private health facilities. It also does not cover individuals from less accessible areas or individuals seeking care in informal sectors. There's also issues of data quality and completeness, which is an issue for the routine data. So that's why we turn to demographic and health surveys. The demographic and health surveys, also known as the DHS, provides data on prevalence of malaria amongst children under the age of 5. It collects this data through a much more rigorous approach, which gives us more confidence in using this to capture transmission intensity. It does have its shortcomings, which I'll describe in the next slide. For intervention effects, we're using data also from the DHS on coverages of interventions. We want to also simulate the distribution schedule of interventions, and so we get that data also from the Nigerian Malaria Elimination Program. The effect sizes for each of these interventions ranging from case management to insecticide-treated nets, we get this from the literature as well. So talking a little bit more about the DHS, this here is a map showing prevalence of malaria amongst children under the age of 5 for 2010. And you see here that this is Nigeria 774 districts, and when you plot the data, you see that there's lots of districts that have no data on prevalence. But we want to develop a model for each LGA. And the issue here is that we need to find a way to come up with data for each of these missing districts. And so to overcome this problem, what we do is that we group LGAs or districts with similar seasonality and transmission intensity together in order to parameterize our model by archetype. And so we're using indicators that are related to malaria transmission, such as monthly rainfall, temperature suitability index, as well as the various vector species. And so we move from 774 sites to calibrate to 22 calibration sites. So once we've calibrated the model, we can then use the model to make historical projections after validation. So the black line you see here is a historical projection for between 2010 to 2019. And then the next step is after the validation and we're satisfied with the structure of the model, we can then start to make compare scenarios. So this scenario here is what we call the business as usual scenario. And these are the round dots are the GTS targets, which I previously described. And what this scenario seems to suggest from our simulations is that if we were to continue interventions in the same manner as previously, that we'll see malaria incidence continue to increase. In the same manner, we also simulated additional scenarios that were proposed by the NMAP, one being a high coverage of intervention scenarios, in this case, all interventions were going to be at a 80% coverage level or greater. And not surprisingly, this scenario pulls down malaria incidence, but does not meet the GTS targets that the NMAP were very particular about finding out which intervention would meet it. We also simulated additional interventions, so a 10% increase from baseline scenario, 20% and 30%. And we see here that small increases in interventions coverages would not get us to the GTS target. We also compared two scenarios that the NMAP had prioritized after considering the cost or the resource envelope for interventions. And this scenario in scenario 6 and scenario 7 were scenarios, very similar interventions, very similar coverage levels, but XMC, which is a seasonal malaria chemotherapy, a full course of malaria interventions that are given to children under the age of 5 during the highest transmission season. The expansion of this intervention was compared between these two scenarios. And while you see that the lines are pretty close together, the burden averted was substantive enough to convince the NMAP to invest in expanding SNC. So we do the same thing with that. We play around with the scenarios that were proposed, and we were able to identify that the 80% coverage scenario would nearly meet the GTS targets and is projected to meet the GTS targets, particularly for 2025. So in essence, our projections supported decision-making for development of the 2021 to 2025 National Malaria Strategic Plan in Nigeria, and was also instrumental in Nigeria's successful Global Fund request for supporting malaria interventions. Using our predictions, they were able to provide evidence for expanding SMC to additional areas that targeted 60 million people. This was also the very first time that models have been used in forms of national malaria strategy in Nigeria. So I'd like to acknowledge all the wonderful group of people that supported this work, from the Nigerian Malaria Elimination Program to the World Health Organization's Global Malaria Program, and my PI, Jalin Gerardine, who has been fantastic in supporting this work, as well as the Institute of Modeling, our colleagues there as well. So thank you for your time, and I look forward to your questions.
Great, thank you so much, Ifeoma. So now we will break for our first Q&A. We're running a little bit behind schedule, so I'll keep this short. I also don't see many questions in the Q&A box. There's one. While anybody else adds their questions there, I'm going to jump in and ask a first question, which was to any of the first two either of the first two presenters, but I'll direct it first to Sveta. Which is to understand, what is the intended audience for the tool that you've developed? And do you have any examples of how this has been used by policymakers or decision makers, or how you'd like to see it used in the future? So I'd love to hear from both of you, but I'll have Sveta respond first.
Sure. Thanks so much, Maria. So I think that this research and work really does have two audiences. So one is the policy audience, and the goal is that the outputs can be used to support task forces that have formed in many countries focused on COVID-19, to have more information, to be able to make more evidence-informed and data-informed decisions as they're thinking about policies, as they're thinking about where to target resources. And for that, we have kind of through this work been having conversations with those types of task force groups in the different countries where we work, and provide these outputs to them, so that then again, the idea is that this feeds into the conversation. So with any type of modeling and any type of research, I think it is important to recognize that it's not that this is the answer, but should feed into a conversation as you're trying to decide how you should move forward. And so we've been trying to basically feed the outputs that are relevant to those task forces and those relevant agencies. In addition, though, I think that the second audience is also a more research and academic audience, especially going into sort of the agent-based modeling work, and that piece is quite exploratory, and there's still it's still a very new area where there's a lot of scope to try new things, to experiment, to see how we can make these models better and more effective. And so we're also trying to push the frontier in that space, and hopefully connect with researchers that are working in this area to push that field.
Yeah, so for us, I think the primary audience would be practitioners, specifically the ones working in primary health, because for primary health to succeed, it is very important to understand what the patterns are in the immediate surrounding areas, and based on experience, what we see is that when setting up facilities, for that example, the only data point that planners have or public health organizations have is of the catchment population in a particular area, and many times even that information has been calculated in with a sort of with a lot of effort. So I think the main idea of this presentation is that there can always more be done with the existing information that health systems collect on a regular basis. I mean, and you just have to be a bit more creative with that. I think a secondary audience for our work is going to be researchers and the academic community, because in many cases the a basic infrastructure of understanding or studying a particular geography does not that exist, and I know that the high cost and high effort of just studying those areas and just deters many academics where areas where research is required. So
thanks, Awaz. I'll leave it there just in the interest of time. But thanks very much. Ifioma, 2 questions for you from the chat. The first comes from Michael Eddy, and he asks if you can describe more about how you included intervention costs and budget constraints into the model. And the second comes from Katie Harris, who asks whether you think a similar modeling framework could be applied in countries in a malaria elimination phase to target resources and prevent reintroduction of transmission. And if so, what are the key ways you would adapt the model?
So really good questions. Michael's questions first. So with respect to intervention costs and budget constraints, we didn't include them in the model, but it was included in the stratification that the NMAP did. So they already costed the plan that the EU wanted, and then asked us to look at the impact of those interventions. So moving forward, I think that's something we would want to assist the NMEP with, including that as part of the modeling framework and using that to inform what sorts of parameterization that we do in the model. But that's something that is still in process, something we're still thinking about and what we're still working on. With respect to Katie's question, that's also a really good question. 3 things that we do parameterize in the model are seasonality, transmission intensity, and as well as intervention effects. And these are things that you can also parameterize for very low transmission or settings. I think with respect, however, you have to be mindful that it's also those areas are areas that have P-falciparum transmission because our model is for P-falciparum. So as long as there are P-falciparum areas, we can use a very similar model to look at the intervention impact.
Excellent, thank you so much. I think in the interest of time, we will switch to our next set of speakers, but please, if anybody else has questions that come up, put them in the Q&A. Speakers, I'd encourage you, if you have the chance, to answer any questions directly in the Q&A boxes, but there will be another Q&A session at the end of the following 3 talks as well. So let me now hand it over to Lupe Bedoya.
Thank you, Maria. I'm going to share my screen. Can you see it now?
Yes, we do. Thanks.
Okay, perfect. Thank you for the invitation. I'm going to talk now about some work that we have been doing in the last years to measure compliance and infection with infection prevention and control practices in health facilities to fight the spread of diseases. This is joint work with a big team, different teams from the World Bank. We estimate that there are 2.6 million people who die every year in low and middle income countries due to unsafe medical care, just in inpatient services. And this was before COVID happened. Of course, the COVID-19 pandemic highlights the role that weak health systems and health facilities could play in speeding the spread of the disease if they have low compliance with infection prevention and control practices. And of course, this is a global priority to reduce the healthcare associated to these infections that create high cost to society, but are preventable with very low cost practices. The challenges that we face is that there is very little research and data to assess the extent of the problem in these low and middle income cities, which will allow governments to design more targeted and cost-effective solutions to diminish or to strengthen these systems. Usually the studies and the data that we see are from small samples, only one domain or one site, and usually relying on self-report that, of course, overestimate the compliance. Just to understand why this is important, of course, a myriad of pathogens have different ways of transmission, so it's very important to understand the risks associated to a location, but also what are the main constraints for that location to be able to design good interventions, so cost-effective interventions. So what we do to address these limitations, we use an observational patient tracking tool to assess compliance with infection prevention and control practices across multiple domains and sites, so that we understand what is the experience of a patient while he or she goes through an entire visit in the health facility. We conducted the largest IPC survey across low and middle income countries in 3 Kenyan regions. And then we adapted this tool for IPC childbirth practices and piloted in Eswatini. One thing that I want to emphasize before we go into the tool is that infection prevention and control practices is a scientific approach. It's a practical solution. It's based on very low cost interventions that are proven to work to prevent harm that is caused with the interaction between patients and healthcare workers while the patients go and seek for care. And I want to emphasize how important this is for patients as it is for healthcare workers, because what we are facing currently with the pandemic is that very weak systems, and even in developed countries, are facing high infections from healthcare workers, which of course makes the situation worse and more unmanageable. And of course, no one should catch an infection while they are just seeking care. So these are just principles from the WHO. In the past, the Ebola outbreaks were identified to be spreading faster because of problems in health facilities. And of course, we don't have currently data for COVID yet, but this may be also one of very relevant elements. So first, I'm going to describe how we developed the IPC tool and the application in outpatient care in Kenya. This is joint work with many members of colleagues at the World Bank. Just so you have a sense, I'm going to describe 3 different data sets. This is a census in 3 regions of Kenya that include private, formal and informal facilities, IP and public facilities. And what we did is first we identified 3 procedures for observation, because it was outpatients. We were very interested in when you go for an outpatient service, what are usually the services that you going to look for. We identify examinations, injections, and lab tests. Then we identified 5 IPC domains for observation: hand hygiene, protective gloves, injections and blood samples, disinfection or reusable equipment, and waste segregation. Basically, we have 20 different practices across these domains. Then we developed and piloted the tool. It's very important that the key innovation, because we base all these tools in validated tools by the WHO and by the CDC, but the novelty is that we combined them and created a process in which we could follow patients through the whole visit and understand constraints across the whole experience through the health facility. And then we collected data in all types of facilities. We used tags to follow the patients, and we collected then information practice where the healthcare worker did what they were supposed to do, whether they had the knowledge and whether they had the available supplies. It's helpful just to illustrate a few examples of a patient journey through the health facility. They go and see a nurse for physical examination, and she should have washed their hands either with soap and water or an alcohol-based hand rub. So the indication is the physical examination. The action is that they had to wash their hands or perform hand hygiene. If the nurse used a non-infrared thermometer, that thermometer should have been disinfected. So that's the action. The indication was the use of the thermometer. And there are, if there is blood draw, there may be, the healthcare worker should have used gloves and segregate the infection waste appropriately. The main results of this study are the first one is that we found a low compliance with overall all the 20 practices that we analyzed. 32% all the healthcare workers did actually what they were supposed to do across 106,000 indications that we recorded. On average, a patient faced 5.1 safety violation through the whole visit. And of course, the more procedures you have, what you see in the figure there is that the different where you have only examination, you face lower number of safety violations. And then of course, if you have the 3 or 4 procedures you face more indications and violations. The second message is that what you see here is the compliance across the different domains. So basically, there is a lot of heterogeneity. That's the first message. The second is that hand hygiene, which is the cornerstone of infection prevention and control, was the lowest at 2%. The highest was everything that was related with injections and blood draw samples, and disinfection practices and waste segregation, except related with needle and syringes, also was very low. We also measure the no-do gaps, and basically, for instance, in here is the example of hand hygiene. So basically, 43% of the healthcare workers knew what they have to do, in which conditions. 70% of them had the supplies available, but only 2% actually complied with the practice. And what we find is like once they are conditioned by supplies and knowledge, the compliance doesn't increase a lot. Basically, supplies are a necessary condition and knowledge, but not a sufficient condition to get to high compliance, which indicates that we have behavioral constraints to address here. There was real progress in some domains. We found 100% compliance with using new needles and syringes, which was not the case 20 years ago. And every time that I present this in African countries, they get very surprised that this was the achievement. There is no big sample data on this. And there was high availability of supply in many settings, in low in another one. So supply don't seem to be the biggest constraint. Now I'm gonna show you the application of this tool by another team in Tanzania. And just so you keep in mind, this is a smaller sample, and it only includes a non-random sample of private facilities in the country. The main message is they also find low overall compliance with the practices analysis. They also find a very low hand hygiene compliance and overall high compliance with injection and blood draw safety, but very, very low disinfection with reusable equipment and also segregation of infections waste. So when we compared both the studies, and again, remember that this has only private facilities and the other one has public and informal, but nonetheless, we can make some conclusions, comparisons if we keep that in mind. Hand hygiene was very low, 6.9% in Tanzania, 2.3% in Kenya. Disinfection also very low in both countries. High compliance with use of protective gloves, and then high compliance with injection and blood draw safety. They also find that there were some issues with supplies, but again, urgent need to improve behaviors, particularly in hand hygiene. Now, what we did is we did an adaptation to childbirth practices and piloted in Eswatini, formerly Swaziland. Very important, there is an important number of deaths that occur of neonatal and maternal deaths every year, and infections are among the top causes for these deaths worldwide. And in this context, we have an additional risk, which is that there is high prevalence of HIV at 27% in the country. We pilot this into high capacity hospitals. So we see how the sample is changing, but even though it was only 2 hospitals, they respond for 46% of the births in Eswatini. So it's very reflective of the best care that you can get, and that a big percentage of the births actually get in the country is a small country. We identify the procedures. The difference before is that in here, if you are going through delivery, you actually have to go through admission, laboring, and either normal delivery of C-section. We identified the same domains, but the practices changed a little bit. So in here, we have 32 versus 20 before. We developed the tool again. All the tools are based on WHO and CDC validated tools. We use tablets. We use, in this case, hospital staff and external assessors, because we wanted to understand whether this kind of data collection can be done for the staff of the facilities. And because all the procedures last for hours, contrary to the outpatients in Kenya, we just took snapshots of key indicators and focus on one healthcare at a time. We measure exactly the same as in Kenya, and just one thing that changes, so that you keep in mind, all of them are going to have a vaginal examination, and there are additional practices like new gloves and the segregation of infections waste that is produced from here. When they're monitoring the labor, they are going to have thermometers and fetoscopes as well, and they have to be disinfected as well. And of course, in the normal delivery process, there is a lot of use of different PPE, sterile gloves, masks, and gowns that are very important for protecting the healthcare worker and the patients. What we find here, again, remember that these are two very high quality facilities. We find overall high levels of compliance, but again, hand hygiene is the lowest at 31%. Remember that the procedures in here also have a higher risk, right? There is more blood involved, and then a lot of interaction for long periods. And we also find that there are important areas of success behind this high compliance, combined with vulnerabilities that point to different places where the IPC breaks. And an example of this is, if we see the PPE practices, we see that usually gloves are used frequently and well, but the mask and gowns are very low at 18%. This is very important in the current pandemic. We found, and in addition, that supplies are an issue, at least supplies at hand, because in another self-report survey from the healthcare in charges of the facilities, they said that supplies were sufficient, but in observation, we find that actually supplies were missing. In disinfection and sterilization, there is 100% in sterilization, but 8% in disinfection. Why is this important? Is because, of course, you can have areas with very high compliance, but at any point that the system is broken, you have the risk of pathogen transmission. And again, we find exactly the same no-do gap. This is hand hygiene again. Basically, there is high knowledge, high availability of supplies, but compliance lags very far behind, and it doesn't matter if you have the supplies and the knowledge available. In addition, because the data collection was a little bit different in this setting, these are upper bound estimates, because we use healthcare workers from the facility. We know that they change their behavior in some ways. For instance, for availability of the hand hygiene, we had a lot of issues in the pre-pilot, but in the pilot, there were sufficient supplies there. All this, a matter of collecting and connecting all the dots here. We are putting an example of 3 pathogens that are very well known: HIV, COVID-19, and Ebola. They transmit differently. HIV, you need actual exchange of different types of body fluids. In the setting of the health facility, use of new needles and syringes is super important, and we find almost 100% compliance across all the settings, which is good. But for all the other ones, COVID-19 that is acquired through close contact with infected people, and through respiratory droplets that are very important in this setting, for instance, of neonatal and maternal care. All the different elements of PPE, proper disinfection, and hand hygiene are super low. Equally for Ebola, who has also direct contact with fluids and tissues, etc. Or many of the practices that are relevant are very low. To summarize, this tool cannot currently link compliance to indicators of health outcomes, so that's a caveat. It's centered on clinical interaction and leaves out equally important elements. For instance, in waste segregation, we know what they did in the facility, but we don't know what did they do with that, whether it was disposed of properly. And healthcare workers in facility can change their behavior. We didn't find evidence of this in Kenya and Tanzania, where there were external assessors, but we did find this in Eswatini. The main takeaways: we could prove that this observational tool was effective for assessing compliance across different settings and multiple domains. Very high consent from patients and healthcare workers, very granular data on a specific local constraint. Supplies were necessary, but not sufficient. And on top of that, when we triangulate, there was over-reporting in other tools. There is great progress in certain domains, like 100% actions on using new needles and syringes. But the biggest element or constraint here is how we change behavior in other domains, particularly in hand hygiene, which remains the biggest challenge for patient safety today. Thank you very much.
Great, thanks so much, Lupe. I hand it over now to Laura.
Great, thank you guys so much for having me. I'm truly honored to be here today. So this is joint work with lots of people, but I'd in particular like to acknowledge my colleagues on the search team. So we often want to assess disease burden and control in our populations of interest. For example, we want to know what the prevalence is of a given condition in our population. And here I'm highlighting population because that includes those who are diagnosed and aware of their status, as well as those who are undiagnosed. Likewise, persons who are in care for their condition and persons who are out of care. Secondly, we often want to know what proportion of the impacted population is successfully controlling their condition. Again, this impacted population includes those who are diagnosed and undiagnosed, in care and out of care, and importantly, with and without measures of control. As a concrete example, consider the UNAIDS target for HIV programs for the year 2020. This target is for 73% of all people living with HIV to be suppressing viral replication. Again, this all people living with HIV really emphasizes that it's a population level metric. And it is simply the number in the total population who are HIV positive and suppressed divided by the number in the total population who are HIV positive. While it's simple to state, it can be very challenging to estimate. Generally, the number of persons living with HIV in the population is unknown. And those who test for HIV may not be representative of those who do not. Therefore, there's a potential for bias if testing is related to underlying HIV status. Consider, for example, health-seeking behavior. Persons with higher health-seeking behavior may be more likely to test for HIV, but also less likely to be HIV positive. Therefore, if we've estimated prevalence by simply taking the raw proportion among those tested, that would underestimate prevalence in the population of interest. Similar challenges apply to measurement of plasma HIV RNA levels or viral loads. And again, there could be a potential for bias in our estimates if measurement is related to underlying viral suppression status. This could occur concretely if HIV positive persons not on treatment are less likely to have their viral load measured. And so what's the challenge we're talking about here today? The challenge is missing data. And as an expert in causal inference, when I think about challenges, what I like to do is I like to pretend I'm this little happy wizard guy over here and think about what do I want and what hypothetical, if not impossible intervention would get me there. And so what I want are these true population level measures of burden and control. And I could get at them if we could go out and obtain an HIV test on everyone not already known to be positive. That includes previously HIV negative or HIV unknown persons. And then I have a second hypothetical intervention to get a viral load on all HIV positive persons. What do we have in reality? In reality, we have incomplete data with possibly differential ascertainments. Importantly, the MCAR assumption, or missing completely at random, is not likely to hold. And I will illustrate how this will be the case even in large studies with high measurement coverage. Those who are measured or tested may not be represented from those who are missed. And our solution here is to treat missing data as a causal inference problem. This allows us to move away from a wished-for causal parameter corresponding to those hypothetical and impossible interventions, instead to a statistical parameter. And we can do this translation under transparently stated and very carefully evaluated assumptions. Without getting into the details, what we're going to do is we're going to use adjustment to quote unquote level the playing field, where within values of adjustment covariates, we're willing to assume that persons with measured outcomes are representative of persons with missing outcomes. But now this presents a new challenge of how do we estimate these corresponding statistical parameters? We could implement a non-parametric stratification-based approach, which simply works as follows. Within each level of our adjustment variables, we count up the number with the outcome, and we divide by the number measured, and then we average the strata-specific estimates. Unfortunately, this approach quickly breaks down due to empty or sparse cells. Indeed, many variables can impact measurement, HIV status, and suppression. There's some time fixed factors, like age, sex, and occupation, but there's also time varying factors, like your whole history of testing, care, and suppression. Another approach we can take, which is on the opposite extreme, is a parametric approach. Two common approaches for adjusting for missing data include parametric G computation and inverse probability weighting. These rely on specifying a parametric regression model to characterize an aspect of the data generating process. The challenge here is correctly specifying that regression. If we misspecify it, we can be at risk of biased point estimates and misleading inference. In other words, wrong answers and wrong conclusions. So sometimes I think when we rely on these parametric regressions, we're being a bit like this little blue guy, brainy Smurf, who runs around town pretending to know more than he actually does. And here's where machine learning comes to the rescue, specifically supervised machine learning, that allows us to estimate these complex relationships in the data flexibly. Importantly, we can avoid introducing new unsubstantiated assumptions during estimation. One particularly promising method is superlearner, which uses sample splitting or cross-validation to build the best weighted combinations of predictions from a whole set of machine learning algorithms. So it's an ensemble or stacking method, which, like Captain Planet, who said by all of our powers combined, we can save the environment, superlearner says by all of our algorithms combined, we can come up with an even better prediction function. And so hopefully you're wondering, why can't I just use machine learning or superlearner in the place of those parametric regressions? The challenge here is prediction is fundamentally different than causal inference, in that they have different goals and thereby different bias variance trade-offs. Equally importantly, there's no reliable way to attain statistical inference when we're using machine learning-based predictions in single robust estimators, such as decomputation or inverse weighting. Thankfully, lots of solutions to this problem have been posed in the last 15 years or so. One solution is known as targeted learning. In particular, targeted minimum loss-based estimation, or TMLE, is a general framework for the construction of double robust, semi-parametric efficient substitution estimators. Without getting into details, TMLE updates our initial machine learning-based predictions to focus estimation to where it matters most for the question at hand, and also allow for accurate quantification of uncertainty. So integrates data adapted machine learning with formal statistical theory. So TMLE is like Robinhood here, where we're targeted to the bullseye, get us the best bias variance trade-off, and valid 95% confidence intervals. So now let's switch gears and apply this to a real example from the SEARCH study. In the SEARCH study, we approached HIV elimination through a broad community health framework. Our intervention was universal HIV test and treat, which is this concept to go out and test entire communities for HIV, for persons living with HIV, get them on treatment as soon as possible, and keep them in care. We approached universal test and treat through a community-based, multi-disease, and streamlined care approach. The overall study involved 32 communities in rural Kenya and Uganda. For today, I'm going to focus on estimating population-level HIV viral suppression in the intervention arm. So this is the proportion of all adults living with HIV who are suppressing viral replication below 500 copies per ml. And we're going to do this with cross-sectional snapshots of community adults over 4 years of the intervention. Oops. In the SEARCH study, we achieve high levels of testing through multi-disease health fairs, shown in the pictures on the right, with follow-up for non-participants. For example, at baseline, 90% of over 150,000 adults tested for HIV at baseline. Using a similar mechanism, we achieved high coverage of viral loads among HIV positive persons and over successive years of the study. Given this large community-based sample, as well as high coverage, it could be tempting to estimate population level suppression with the raw proportion, i.e. relying on that missing completely at random assumption. And so here are the results if we do. On the graph on the right-hand side, we have the study year on the x-axis from baseline to the year 3, and the y-axis is our estimates of population level HIV viral suppression in percent. And so what we can see here is this unadjusted approach of simply counting up the number with the suppressed viral load and divided by the number with the viral load measured, suggested that 50% of all adults living with HIV were suppressing viral replication at baseline, and this jumped to 80% within 1 year of the intervention. Now let's see what happens when we do some adjustments. So here in medium blue, we can now see the results when we stratify on sex, age group, and community. And we can see here that stratification on baseline predictors yield slightly lower, but not meaningfully different estimates. And finally, in dark blue, we now have our fully adjusted estimates. So these are controlling for baseline and time varying predictors of measurement and health outcomes using TMLE with SuperLearner. And we can see that across the time, full adjustment yields substantially and meaningfully lower estimates. And for you, those of you who do not work in the HIV prevention field, I really like to stress that these are meaningfully different and could impact policy decisions, patient outcomes, as well as allocation of limited resources. So I want to issue caution when relying on the missing completely at random assumption or only baseline adjustment. Instead, we are often far from MCAR, even in large studies with high measurement coverage. Machine learning can help us flexibly control for differential missingness or measurement, but it is not enough. TMLE with SuperLearner is a powerful tool for estimation and inference of causally motivated statistical parameters, here controlling for both baseline and time varying predictors of measurement and health status in infectious disease research and response. With that, I'd like to thank you for your attention, thank the organizers, thank NIH and PEPFAR for supporting SEARCH. We're grateful to all work on SEARCH, our multilateral partners, and the communities we serve. And finally, I'd like to acknowledge some of my colleagues from across the world. Thank you very much.
Thanks, Laura. I will hand it over to Jonathan, and just let me note to all the attendees to please put your questions in the Q&A box. After this presentation, we'll break for the final Q&A. So questions are welcome at this time. And here's over to you, Jonathan.
All right. Hopefully people can see my slides. Thank you for having me, as is often said, now for something completely different. What I want to present today fairly quickly is some work that I've done jointly with Netta Augenblick, who's also at Berkeley, Ziad Obermeyer, who you've all seen earlier today, and Al Wang, who's a PhD student here. We're going to be interested in hopefully what becomes a relatively simple point at the end, but how to think about different aspects of particularly frequency in considering testing for COVID, where we're going to talk about here, and we think a more general insight with respect to other infectious diseases that are maybe circulating, where you have both temporal and cross-sectional variation in prevalence over time. And I would note that, and I'll come back to this, it was previously circulated as a different title, Group Testing in a Pandemic, the Role of Frequent Testing, Correlated Risk, and Machine Learning. I'll actually comment a little on the machine learning at the end because of this audience, but that's not really in the paper anymore. It's a very focused thing. Well, hopefully it's focused. So what are we talking about? We're talking about COVID-19, and particularly we're talking about the fact it's hard to contain because it spreads freely through asymptomatic individuals. So we're increasingly learning that asymptomatic spread is material and important. There's lots of strategies. They're all happening at different paces and with different combinations. We're going to focus on testing, which is the topic for today. You know, certainly some places are getting high vaccine rates where testing is becoming less important potentially, but it remains a critical piece of the puzzle. And certainly other places where the vaccines are likely more distant, I think these solutions are potentially very important. So here's the basic idea. COVID spreads through people who are asymptomatic, right? The symptomatic testing that has been done in very different ways is probably not sufficient or not sufficient. The idea is imagine frequent mass testing, right? Something like every person every day. Effectively, infections could be quickly discovered in quarantine and you'd stop the spread. So this is not necessarily a new idea. It was sort of surprisingly under-discussed at sort of the concrete level of how frequently it could run and how effective it could be. But the problem, and to be clear, we began this project focused on a US setting, but we think this is broadly true and applicable, is that it's too expensive to run the gold standard PCR test. It's $100 or more and per test, and that's too much, right? So we need innovation to bring the cost down. What has been proposed is antigen tests that are in many cases much cheaper, but they have a lot of issues, which I won't dwell on today, but they're much less sensitive and potentially much less effective. What we're going to focus on is basically the idea of taking group or pooled testing, an old idea that can leverage existing infrastructure, PCR lab testing capacity, and make it what I'll argue is much, much more efficient. So let me just walk through. I'm going to basically build this up in a simple set of a simple setup. And in general, these results are kind of without loss of generality to more complicated alternatives. There's a gigantic cottage industry of how to do more efficient pooled testing, and I'll come back to that a bit. So let's suppose there's 20% of people, each with a 1% of risk of infection, right? We could test everyone individually. That would be 20 tests. Alternatively, we could group samples and test the whole group, right? If we get a negative group test, which happens with 82% probability, everyone's cleared with one test. Now, if we get a positive test, we can just retest them, but then we've only spent 21 tests total in that 18% of the time. So the expected number of tests for the group has dropped substantially to 4.6 tests or 80% savings. This is not even remotely our idea, right? This is a classic way to do pooled testing going back to Dorfman's work in World War II. It's been used in lots of other settings, including notably HIV testing. But those settings and the settings for which it is designed are in general quite different than a rapidly spreading infectious disease with both spatial and temporal variation like COVID. And that leads to a key additional insight that can really change the efficiency of pooled testing. And really the key intuitive point that we want to get at, which is true across all kinds of group testing, is that when prevalence falls, expected test drops. That is to say, at lower prevalence, group testing is more efficient. Now, you've heard in practice lots of rules of thumb being tossed out, I would add, with very little actual data to support them, basically saying if prevalence is too high to do group testing. We can't do group testing with COVID because prevalence is too high. This embeds in it the fact that group testing is much more efficient with lower prevalence. And so if you think about it, just in our example, let's suppose the infection probability dropped by an order of magnitude. In that simple example, you'd go from 4.6 to 1.4 tests, right? So more savings with lower prevalence. That's also not new. The important thing that we're pointing out is that frequency interacts with prevalence, right? And if we wanted to test everyone once a month, it would cost us this 4.6 tests, right? If we say there's 20 people, once a month, 1%, same thing. Now, let's suppose we want to increase that 10 times. We want to test them 10 times as frequently. Naively, you might say that basically we would need, well, if we want to do individuals, you need 200 tests. But naively, you might just scale up the efficiency of pooled testing and say, well, that's going to, even with pooled testing, that's going to take 46 tests, which is certainly a savings relative to the 200 tests, but it looks like it's getting much more expensive. In fact, it's getting 10 times more expensive to test 10 times as frequently. The answer to that is that it's not actually the case, right? That's not the case. And the key lies in that intuitive observation that lower prevalence makes group testing more efficient. And if we've actually tested people already, the incremental risk that they're actually sick or has gone way down, right? So let's think about it, that if we've tested everyone, I mean, in the extreme, imagine we tested everyone an hour ago. No one or very few people would have become sick in the last hour. And so the positivity rate or the probability that someone is positive will have dropped. And this drops the expected number of tests. Therefore, in the simple example, increasing 10 times, you'll only need 14 tests for each of those people, right? So the prevalence rate has dropped. And this is a more general observation that as you have higher frequency testing, you lower positivity rates, you lower prevalence, and group testing efficiency gets higher. basically there's this quantity or frequency discount that is very large with respect to pooled testing. That is, you can buy 10 times the tests for only 3 times the price. And more generally, we proved the result that basically if you get X times more tests, roughly the incremental cost only goes up by the square root of X. So you can get much more frequent with much lower cost increases. So to use my telesales version, that's not the end of it. There is more here. And the key is that we ignore an important benefit of frequency, that we've just sort of had this independent probability of risk. We're saying that pooled testing is more efficient, but if you detect a sick individual earlier and take them out of the population, right, ask them to quarantine, you're also lowering spread. Remember here, every time you lower spread, it makes pooled testing that much more efficient. So you have higher frequency, you're going to catch people earlier, you have lower spread, you have even lower prevalence, and even higher group testing efficiency. So if you put that in and add, in our simple example, taking spread into account, if you increase testing frequency 10 times as much, so 10 times as much testing, you're less than doubling the total cost of testing, right? And so it's a way to make a high frequency testing much more affordable. And in fact, this can be even more powerful under certain scenarios. And this depends on the underlying parameters, but it is generally true that it's possible that when you're testing more frequently, you can get this very counterintuitive result that you can actually increase your testing frequency and actually reduce the number of tests overall. And how? It's basically to do with the exponential spread. So over certain ranges, as you catch more people and remove them from the population, prevalence decreases very, very rapidly. And essentially you can find ranges over where you can double the rate of testing and reduce the total cost, the absolute total cost. I think more generally, the observation is that testing more frequently is much cheaper than we had typically believed in terms of using the high performance tested PCR testing. And you can see that here. This is a plot from our stylized model, but as I said, it depends on the parameters, but it's certainly the same intuition holds. Here we see the number of tests needed on the x-axis here. So even as you increase frequency, right, the rate of optimal testing, with optimal pooled testing, the rate is not increasing very rapidly. And what you also see is that the infection rate in the population is dropping off dramatically, right? So moving from monthly to weekly testing with some pooled testing ranges actually lowers the total cost of testing and dramatically lowers the infection rate. And you can see that this continues out, but has a diminishing marginal return. The main point in practice, and when we've implemented this, is that you can move to monthly or biweekly testing of entire populations at either very little incremental cost or even in some cases lower cost. So there's a second piece to this, which is a natural relationship, which is it's not just the frequency, it is also it's not just the frequency, it is the accounting for correlated risks. And the idea is that if you have people that are naturally going to be infecting one another, for example, families or coworkers, you want to pool them together. And in fact, you can form much more efficient pools by adding correlated risks, right? Simple, imagine a factory shift with 20 people with independent risk of 1%, right? The probability that the group is positive is 18%. But what if we have perfectly correlated risk of 1%? We actually only have 1% probability, right? So effectively, if you have correlated risk, you're getting more efficiency out of the pooled testing. Now, in practice, that this has been sort of all of the results and the focus on forming pooled testing and the efficiency of pooled testing is based on independent risk. But that's not naturally likely, particularly in the kinds of infectious disease settings that we're talking about with COVID or other future easily transmitted diseases, right? A family or a dorm room, people are clearly infecting one another, right? The probability I'm affected, given my son is infected, is greater than the probability I'm infected. And because this helps in group testing efficiency, it actually has this natural corollary, which is rather than doing what might seem a more complicated or diffuse collection, you can just imagine collecting samples in a way that's aligned with the natural spatial or risk distribution of the population you're sampling from. So for example, rather than having one clinic where everyone goes to, you just go out and collect samples from people when they arrive at a work site for a shift, because those are precisely the people that are interacting. So it has this added bonus of mapping to potentially a logistically more feasible way to gather samples. All right, so I've tried to be relatively quick and keep us on time, but the main punchline of the paper is that there's this important interaction of frequency and pooled testing that leads us to much more efficient COVID testing. We're talking increase or reductions in cost of more than 90%, and in fact, cost structures that are lower cost than existing antigen test solutions that are for individuals. I'm focused on this for COVID. This has important implications for lots of other infectious diseases, either ones we have today or ones we should be planning for, and I think increasingly we'll have the resources to plan for, given what's happened with this pandemic. This is not just a theoretical point. This insight is actually being implemented in a couple of different settings. I think most notably, all of the public schools in Massachusetts have reopened with weekly pooled PCR testing. We were involved with advising on that, so it's not random, it's correlated, but it's proven to be very efficient. And I'll note that the paper predicted that you should be able to do weekly pooled PCR testing at about $5 to $10 per test, and the market price in practice for Massachusetts students is $7. So it does seem like these efficiencies have shown up. This also matters for policy and market implications. So if you're thinking of a government setting subsidies, it's not that there is a role for encouraging this kind of innovation. And I'm happy to go into this in questions. We've seen a lot more innovation on private innovation like antigen tests, and much less on using existing capital more efficiently. And I would argue that if governments are paying for testing, they should set standards for frequency and test performance that basically encourage these kinds of innovations. Of course, if an antigen test can do better, they should be rewarded. But this can be a way to facilitate entry into these markets. And we've seen that work, for example, again, in the Massachusetts case. I would add that surveillance testing really can dramatically lower prevalence. So I think, certainly in the US conversation, testing was a political football, but we're seeing now, notably in schools, that large-scale surveillance testing can be very effective. And I think in other countries where we're going to have to need testing policies, this kind of high-frequency correlated risk, it lends itself to applying these techniques and using existing PCR testing capacity effectively, and it works well, again, for organizations. Lastly, I'd say for the interested party, given the audience here, we also developed some results showing that if you have machine learning tools to better predict risk, for the same reason that we talked about correlated infection and the need to understand risk, if you can use machine learning to predict risk, that can also be used to form pools more effectively. And I'll end with saying, hopefully, these insights are not just useful now. Obviously, COVID is germane for quite some time, but in thinking about future pandemics and the need to be able to scale and respond with testing capacity quickly, I think these insights may be useful. So I will stop there and turn it back over to Q&A. I believe I'm roughly on time.
Yes, thank you so much. And I'd invite all of the presenters to put your video on at this point and can answer questions. We do have one question in the chat, which I will share, but I'd also encourage any of the other presenters to take time to offer any reactions or thoughts on other work that you've had today, that you've heard today as well. So let's start with this question from Neha in the chat, which is for John. Have you considered the test results of sequencing from nanopore technology, which is highly mobile and requires lesser infrastructure? And I guess a related question is from Awaz about whether you've considered efficiency gains from rapid antigen testing. So maybe just thinking about some of the alternatives.
Yeah, more generally, I would say we've thought a lot about this, and that's been, I describe it as the waiting for Godot problem, that a lot of the existing solutions we could have been implementing a long time ago have been put on hold because companies don't want to enter because there's always waiting around the corner some technological solution. At the end of the day, the sensitivity of these, all of the tests to my knowledge are not particularly high. They're much worse than an individual PCR, and they're typically 1 to 2 orders of magnitude worse than even a pooled PCR at the scale we're talking about. So particularly in thinking, that I've done a lot about kids where we're trying to do this in school, you need the sensitivity and you need to catch it early. And as I said, with these results and with the right frequency, you're actually getting cost structures that are in many cases lower than existing antigen or other kinds of technology solutions. They're, in practical terms, we need all of it because we're under capacity in terms of testing. So it's not an if or. The only if or that I think is important is that we need entry into this market by the bigger labs with these kinds of innovations. So I've been very encouraging of, as I said, you set frequency standards for what surveillance testing is, and you set limits of detection for what a reasonable test is, and then you let the market enter. But increasingly, these rapid antigen and other things are being used where they don't perform as well, and you get lots of negatives, but it's not going to give you the same performance. The last thing I'll say, and then I'll be quiet, is often the turnaround time is held as very, very important. But for the same reason that I was saying, if you have a systematic surveillance in effect, you care less about the turnaround time because the probability of infecting someone is low because you've shifted prevalence down in your population. So in terms of actual infection spread reduction, you don't get much return between, say, 15 minutes versus 24 hours because you have higher viral loads coming in. And I would lastly say that even with 15 minutes, if you have a large workforce, we've seen people say, well, if I have to do them all before they arrive, that's still a logistical problem. So I'd rather go through the workplace over the course of the day, have everyone's results for the next day, and quarantine whoever doesn't need to be tested.
Great, thank you. I don't see any more questions coming in from the audience, so maybe Laura, let me pose one to you. I'm curious, given what John was just presenting on pooled testing, whether that's something that you've thought about in the HIV context and how that might factor into some of the work that you were talking about.
Yeah, thanks so much for the question. We have not thought about pool testing. We have more thought about all of the ways in which that we can eliminate all the barriers to get entire communities tested for HIV, including not making it be about HIV, really being about multi-disease healthcare, bringing it into the community, taking it to the people, figuring out what they want. So I think pooled HIV testing is really important and interesting, but it's not something that we've explored in our settings.
I would just add that there's a lot of great work on pooled testing that comes from the use of it in HIV for these kinds of efficiencies. Fortunately, in general, the spatial and temporal variation is lower than what we're talking about with COVID, and that's, I think, that's actually one of the biggest things is to revisit it with it's been really thought about in those contexts, and this is COVID and other infectious disease might be different.
Great. Let me just open the floor briefly to see if any of the other presenters, also the three who were in the earlier half of the session, have any comments or reactions to share.
Yeah, I do have a question. For Laura's presentation, I was wondering whether she used any sort of simulation data or fake data to validate her models, and in terms of accuracy, how are you measuring that for the missing data?
Yeah, fantastic question. So all of the methods were pre-specified because this is a trial, and we've done a ton of simulations that somewhat mimicked what we thought we'd see in the field to validate the methods. I think it's really important to note here that we were able to control for missing data because we knew who were missing. So at baseline, we did a rapid census, which allowed us to know which persons we didn't get an HIV test on and their baseline characteristics, as well as who we didn't get a viral load on.
Thank you.
Thank you.
Wonderful. All right. Well, a big thank you to all of the panelists. This was really, really interesting work to hear about. Thanks for taking the time to share.